Okay, okay, good. All right.
Oh my gosh. Okay.
Okay.
So wait, so anyway, Heather is my client for non-opioids. And
Hello, everyone. We're going to get started shortly. It's almost 3 o'clock, and we've got a lot of information to share with you today. And I want to be respectful of everyone's time.
Okay, Marsha, are you guys not going to share I can pull those slides up. I didn't have them up, but I can pull them up.
You should do it. You should do it. Mm-hmm.
All right.
Okay. And Carrie, would you just share with everyone some of your background as well? I was going to read it off, but
Yeah.
okay.
It's okay, Marsha. Let her do it. Okay, go ahead. Mm-hmm. Yeah. Carrie, go ahead.
Well, I'm happy to do it. So I'm Carrie Rhodes, and I'm honored to be with you guys today. And I will share my screen in just a second. But just to give you a little background on me, I've been a therapist for 28 years. I've actually taught mindfulness. I use EFT in my practice now. So when you all are talking about, non-opiate medical and non-medical solutions, those are near and dear to my heart. Part of why those are near and dear to my heart, let me see if I can share my screen with you guys. Let's see. It's not letting me share my screen, so that's not good. Let's see here.
Raj, you have to give her permission to share the screen.
Yeah, it's not letting me share what's on my desktop. Let's see here. Sorry for the technical difficulties, guys. Let's see.
Lauren, are you on the line? Can you do that for me? Because I don't see where to do it. I have my settings set up so anyone should be able to share a screen. I always do that ahead of time.
Are you a host, Roz?
Yeah, hello. I'm not, it says I'm not a host, so I can't.
Roz, are you a host?
Yeah. Mm-hmm.
And on the bottom, there's a share screen button and there's an arrow next to it.
Okay.
And you've got to click on the arrow and you've got to allow others to share their screen.
Okay. Hold on. Let me see. Thank you. Did that do it, Carrie?
Let me try here. Hang on just a second. Let's see. I'll try here. And it's not giving me my desktop yet. No. Do you guys have the 2 slides I sent you? If anybody can pull that up, you guys may be able to share it easier on your end than I can. It's just one. If you just pull up the 1 slide with the pictures of my
but
kids.
it says all participants can share. That's what it says.
Mm-hmm. Yeah, it's not giving me the ability to share, so I'm not sure why that is. And I use Zoom all the time, but it's not giving me. Let me see. Yeah, I don't know what that is. It's telling me I can't. It's not showing me anything on my desktop. It's giving me a triangle with an exclamation point in it.
Oh, okay. Wait a minute. I see. There's 2. See, Zoom has so many layers. There's 2 functions. Okay. I didn't click on the second one. You should be good now.
All right. Let's all pray. Let's all pray.
I'm sorry. There's 2 layers that you have to approve.
Yeah. No, it's still not letting me go through.
It's still.
It's not letting me. It's not letting me go through. it's telling me to open system preferences and do some other crazy thing. Let me see here.
Because I pulled up who can share and who can start sharing,
Mhm.
and it says all participants. I did it for both.
Yeah, no, it's not letting me. Let me see something here.
Unfortunately, the other host, I thought I had made Lauren a host for this meeting. Well, wait a minute, hold on. Let me see if I can make you.
Hang on
Because
for a
the other
second.
person who's supposed to be helping us with this is not available. Okay.
Let's see. I think I can.
Okay, Lauren, you're try it now, Lauren.
All right. All right, we made it. We made it, guys. All right. So are you all, just so I can check Rosalind, are you all seeing the slide with my family on it?
Yes.
Okay, perfect. All right. So my name is Carrie Rhodes. I've been a therapist for 28 years, but I'm here today to talk to you as a mom. My son, Taylor, had shoulder surgery at the end of 9th grade and was given a prescription of Percocet to manage his pain. And what we didn't know then that we know now is that that lit a match in his brain and began us down a road of addiction and substance use disorder for him. He by the end of his 10th grade year, we knew that we were in trouble. And if I could go back and, when that doctor handed us that prescription for opiates, there was no warning. There was no, this puts your child at greater risk. Everybody who takes, opiates has a significant chance of addiction. None of that was explained. It was a prescription and, you leave. And that started for our family a nightmare. And that nightmare ended with his overdose about a year and a half ago. It was June of 2019. He was he'd been in recovery for 10 months and he was going back to college. He was taking some classes at NC State when he had an accidental overdose. He had relapsed and whatever he took had fentanyl in it, and he died. I'm gonna let, we have a link here, and it tells you his story better than I can, and it's a lot more concise. So I'm gonna have you guys watch this, and then I'll finish this story for you guys. But what you all are doing today is incredibly important. Having non-medical and medical, non-opioid solutions is the difference in life and death for many families. And once that switch is flipped, for addiction and SUD, there's no one unflicking it, and you are in a fight for your life and your loved one's life. And as somebody who had a lot of resources at my disposal as a therapist, my husband works for a huge health insurance company, so we had lots of resources at our disposal, and none of it was enough to save our son. And so the best thing we can do is never let it start for families, and non-opioid solutions is a big part of that. So I'm going to share this story with you guys for a few minutes, and then I'll wrap up and let you guys get on with your day.
Every day since Taylor died, I started to write, "This is from day 34. I tell myself over and over, I will not let this all be.
We're not seeing the video, Carrie.
Because you were.
Okay.
We're still seeing the slides.
Oh, let's see. Yeah, you guys should be able to see the video if you're seeing my screen. Let's see here. Let me exit back out. Let's see here.
Do you have to click on Taylor's store? Oh, there it is.
Yeah, I clicked on it. That's what I clicked on, and and I can see it. So I don't know why you all are not seeing it.
Now we're seeing your name. There it is.
Are you all seeing that where it says YouTube?
Yeah, now you just have to make the screen, just enlarge your.
Oh, I will. That's what I had on before. I'll back
Yeah,
up.
yeah, we couldn't see it. Now we can see it.
Okay, let's see here. Are you all seeing
Every
it big
day
now?
since Taylor died, I started to write
Yes.
from day 34. I tell myself over and over, I will not let this all be for nothing. I will be honest and vulnerable and brave because you were. I will show the good, the bad, and the ugly. You and I will own this story, and we will walk inside it together, just like we did for 20 years and 12 days. Love, Mom.
Oh yeah, that's one of my favorites.
Mhm.
Taylor was the big personality in the family. I don't know that he necessarily always wanted to be center of attention, but
He liked to live life big. He came out with a foot on the gas pedal. He wanted to go, go, go.
He was fearless. He was going to do anything to kind of achieve his goals.
he had a huge heart, extremely loyal, maybe to a fault at times. He just loved big.
He taught me a ton of life lessons, and his addiction probably taught me the most important ones.
He was a great athlete. He could do anything he wanted to do. At the age of 14 or 15 years old, Taylor had a pretty significant tennis injury.
Started with a shoulder surgery and a bottle of Percocet to manage his pain, and that was the beginning.
It was years later that he would tell us that when he took that Percocet, it was the first time his brain lit up. It was the first time he felt normal. It was the first time he didn't feel anxiety. He didn't feel depressed because he had a history of anxiety and depression. And he said from that point on, he was hooked. It wasn't necessarily, it was just opiates. It was Xanax, pot, alcohol. Sometimes it was just whatever he could get his hands on.
He'd say, well, I'm not doing anything different than other kids were doing. And he was right. He wasn't. But, he knew that every time he touched any of those things, his life went terribly wrong. I mean, terribly wrong.
Seeing it consume him in a way and consume our family, I kind of isolated myself. I had no control, no influence on what he did next. It's pretty a lonely place, honestly.
It is like grieving a child that you love more than anything, and they're standing right in front of you, but you don't recognize them. You see the drugs, and they're vacant.
There were times where I was very angry at him. There were times where, I was ashamed of him. Most of the time, I was very sad. And as hard as we tried, we couldn't help him. We struggled to try to find good, compassionate care time and time again. Even when we did, it was extremely fragmented.
We have these siloed models with mental illness and substance use. We've either picked one or the other. And as a mental health professional, I could not believe it.
When Taylor was in treatment, oftentimes, they just wanted to treat him for his addiction. If you don't treat the underlying mental health issues that typically come with addiction, you're only treating maybe not even half of it.
There's an urgency in treatment, and the gaps are big. And with things, being tainted with fentanyl these days, every relapse is potentially your child's death. And that's what happened to Taylor.
When you're the parent of someone who's suffering from addiction, you play those moments over in your mind periodically when you're going to get that phone call. But I can tell you, it doesn't prepare you for when it really happens.
I couldn't even breathe. I couldn't breathe to know that your son, doesn't get another day. I don't get to see him get married. I don't get to see him have kids.
He was just such a huge part of our family. We'll just never be able to experience that anymore.
Just having someone take on life, even when my parents circle, Never did want to be an only child. Yeah.
Taylor had several tattoos. One of his tattoos was a quote, "If you think it's hard to watch, imagine how hard it is to live." All he wanted was for people just to love him, and at the end of the day, treat treat him like anybody else. So our plight, our journey from now till the time we can't, we're going to spend most of our energy trying to help those who are facing the same struggle that we faced.
I just, want it to be treated like any other disease. They're normal people that struggle like everyone else.
They're people that people love the most in this world, and we don't treat them like that. We treat them like it's some moral failing or some lack of willpower, and it's not. It's a brain disease. Behind the use is this beautiful person who has a family and who is loved by people. I hope when you hear our story, you think about it differently.
Every day I try to honor him because he's worth honoring.
All right.
Okay, Carrie, thank you. That's, as I said, it's a very powerful piece.
Wait a minute, Marcia, she hasn't finished. She hasn't finished. Yeah, she hasn't finished. Let her finish. Go ahead, Carrie.
Yeah. So, I don't ever watch that thing without being in tears, because it's a tough story. But, the piece of the story that I hope all of you walk away with today was that, and I truly believe that it was that Percocet prescription, and he said that over and over again in his recovery. He said, Mom, when I took those opiates, it was the first time my brain felt normal. And I work with a fair amount of young people struggling and in recovery, and many of them have that same story. And, the solution in this is to not let it get there. My daughter, who, you all saw in the video, she's a college athlete, and 3 months ago, she had the exact same shoulder injury that her brother had. And when we met with the surgeon, we sat down, and as they explained the surgery, which we were very familiar with because my son had had it, I had actually had the same surgery. He said, and when she leaves, we'll give her a prescription of Percocet and to manage her pain, to which I quickly, spoke up and said, she will not have opiates. And they pushed back and argued with you about it. And they said, well, she's going to need it. It's super painful. And, it wasn't until I really drew that line, I said, she will absolutely not have opiates. And they said, well, we'll see what we can do. Because when you explain to them that opiates killed your son, they're quick to stop arguing with you about it. And they did find a non-opiate solution and for her, and she had a medicine that makes your numbing block wear off very slowly. Instead of wearing off in 8 hours, it wore off in her case 6 days. And so she managed her entire shoulder surgery with Tylenol. And our family is the poster child for what non-opiate solutions can do for people. I think many people don't know about them. I think doctors are used to doing what they know. And the thing I think that struck me, in the 5.5 years between my son's injury and my daughter's, was that nothing has really changed. The protocol that doctors and orthopedists are going to is exactly the same thing it was 5.5 years ago. And, frankly, many of them do what they know, but they don't see the results of what they're doing. I mean, we all know we have an opiate epidemic. And I think until it touches your life or touches somebody that you love, it's just a headline in a newspaper. And for our family, it's not. But I am so grateful that all of you are doing what you're doing to fight for families like mine. And, and we feel very strongly about advocating and using our story, as hard as it is to tell, to say why that's so important and why we just have to do better. We have to do better. And I believe that, there's a lot of emphasis on treatment and better treatment and things we can do once people are struggling with substance use disorder. And as a parent, I think our best efforts are spent, going upriver and never letting them fall in. Once they're in the river, we're in trouble. But if we go up the riverbank and stop them from falling in the first place, and I think non-opiate options are a big part of that in this country. And so, the United States, I don't know if you guys know this, but, we use 95% of the world's opiate supply, and we are 5% of the population on this continent. And so I think that, that was something that always stuck with me. And I thought, how can this be? But, people like you and people like me, hopefully together we can change all that. So I think what you guys are doing today is really important, and I'm really, really grateful and honored that you all would let me share our story with you today. So thank you so much for your time.
Well, thank you. And I know we have a full agenda, but the other thing, Carrie, that struck me when you shared your story on Tuesday, can you just briefly share when you were pushing back before you had to tell them about Taylor, when you were pushing back on the use of non-opioids for your daughter, why they told you that they were reluctant to do it until you pushed them to that point?
Sure. So when I said, why are non-opiate, why is what my daughter got not the first thing that's being offered to people? And what they said was, well, it's expensive. Well, losing your child is pretty expensive. But the reason it's expensive to doctors is that in our country, what happens is, so if a shoulder surgery, let's say a doctor gets paid $20,000 for a shoulder surgery, what happens is when you ask for that non-opioid solution, it comes out of the doctor's cut of what they get paid. But a prescription is just our pharmacy benefit as payers. So there's a disincentive for doctors to offer that. And I also think doctors do what they know. And most people who are practicing right now were taught pain's the fifth symptom. If you don't treat it, you're not a good doctor. And it's easier just to write a prescription because it manages people's pain in the short term pretty well. And we don't have to hear from patients at 2 a.m. who are in excruciating pain. But I want all of you to know, and I hope you share it with everybody, that there are options and they are not expensive options. The No Pain Act that they're trying to put forward on a federal level right now will level the playing field and give all of us and enforce insurance companies to make those options available to us and have them covered, have those non-opiate pieces covered. But you can't put a price on losing your child. And we know that nobody starts with a needle of heroin in their arm. That's not how anybody starts. And most 50% of all people who have substance use disorders start with prescriptions in their home or that they're prescribed legally by a doctor. And just because the doctor says, hey, this is what you need, we as consumers and parents need to be way more savvy than that and demand better, because until doctors do better, we need to do better.
Wow. I wanted you to share that point, and you I'm not even going to add to it what you said, what needed to be said, but that whole expense thing struck me hard when you mentioned that on Tuesday. And so the No Pain Act, yes, we need to talk more about that at a different time, but I just wanted people to be aware who are not following this issue as closely as you are and as closely as I am, to be aware of that you're going to get some pushback, unfortunately, until we do change the culture and the insurance mechanisms.
Yeah, and that medicine, it literally, the dose my daughter got cost $175 because I went and checked. And so to me, that, it's a little more expensive than, but I would have paid that in a heartbeat if I could have avoided what happened to my son. And the truth is that you couldn't go. A lot of insurance companies make it so you could say, well, I'd want to pay that $175 for this option, and you wouldn't be allowed to do that. And that's just, it doesn't make sense, but common sense is not so common. But we really, I feel honored to be here and talk to you guys. And I love what you guys are doing and what's on your agenda today. I think all of it's important. There are lots of solutions, medical and non-medical, out there that we need to make sure people know about.
Thank you so much.
Right. Before you go, there's just one other aspect that I wanted you to share. I understand that you had been advocating for the opening of a recovery high school.
Yes,
okay. And could you share just a little bit with that? Because I was surprised to really know that there would be enough of a population that would actually take advantage of something of that nature.
Yeah. So, another thing that people maybe don't know is that in this country, there are no protections for our young people that struggle with substance use disorder. And the number one symptom of substance use disorder is use. So in this country, 504 law and IDEA, which govern services in schools, exclude students protection because they use. So if you have an illegal substance or if you've used an illegal substance, you are not protected. which is just crazy to me as a parent. I've been in the school system for the last 12 years, and and I've seen what's out there. My son, when he struggled in high school, there was nothing for him. There are about 40 recovery high schools in the country. In my area in Central Virginia, we could fill a recovery high school, and it's to me like asking a young person who's struggling with a substance use disorder to make it in a traditional high school would be like you or I being compulsive overeaters and somebody saying, here, go work in a bakery and work on that. There's too much out there, and in order to be successful and stay in recovery, young people need to be surrounded by other people in recovery, and they need supports. They need medical supports, they need mental health supports, they need educational supports, and they need to be surrounded by people who walk that walk and who are on that same journey. And a recovery high school will do that. Last year in the Virginia General Assembly, we Kerry Corner introduced House Bill 928, and it would have established the first recovery high school in Virginia. We got it through both houses because it's really a nonpartisan issue. But the issue is always money. We got about a third of the funding we needed. COVID hit, all the money that was allocated was reabsorbed into the budget in Virginia. But students who struggle with substance use issues are suspended or expelled, and many of them are denied their education. And that is not okay. That is not okay. We don't do that for students who have cancer. We don't do it for students who have diabetes. And addiction and substance use disorder is a disease. It's a brain disease. If these kids could stop, they would. I can't tell you how many conversations I have with my son who said, I do not want to have this. I do not want to struggle with this. Nobody who gets there, nobody thinks about if they're smoking pot or they're drinking or then nobody thinks, well, I can't wait to become an addict when I get older. But the truth is that those things, can grab you at any time, and kids that are using are playing Russian roulette with their brain. A recovery high school would give us a place to help those kids and families that are in crisis, because right now they're being absorbed into our justice system and they're being put out on the street. And I'm not good with that. It would have been a great resource for my family and my son. And we didn't get it this go around in the General Assembly, but we may figure out a way to do it privately or with private funding or some other way. But I know in y'all's area, I'm sure you have the same problem we do. But we have a lot of kids struggling and a lot of families not knowing what to do.
Wow. Thank you so much. And would you type your contact information, okay, in the chat so that if individuals wanted to reach out to you, they would be able to do that? I know it was on one of the slides in the video, but if we put it in the chat, okay, folks can reach out to it as they need to.
Perfect.
All right.
That sounds great. Thank you so much. I sure will.
All right. I want to take this opportunity now to introduce you to our moderator for this afternoon's panel. And I'm very happy to have Ambrose Lane as the moderator for the panel. Ambrose is a native Washingtonian and has been very, very active in community issues for over 25 years. He is the founder and executive director of the Health Alliance Coalition, which is the largest coalition in the city that focuses on the problems of health disparities in the District of Columbia. So at this point, I'd like to turn this afternoon's town hall over to Ambrose.
Thank you so much, Marcia. I really appreciate it. And no, I was born in Pittsburgh, Pennsylvania.
Oh,
just know that. But I have been either in DC or near DC since 1979 when I entered college at Howard University.
okay.
So I've been here for quite some time. So I just want to thank you and the Ward 5 Drug-Free Coalition for putting this on. And I was also really moved by the story that Carrie Rhodes shared with us about her son. And I don't want to belay, I know that we have little time left, on this webinar, but I'm just glad to be here, and I'm glad to be able to talk to and generate discussion with some luminaries that I feel are luminaries in their field, our panelists. And so without further ado, we're just going to jump right into it. And I do want to hear more from Carrie about the fact that how difficult it was for doctors to prescribe alternatives. I mean, that really did strike me as well. And I was not aware of the impediments that the health industry has when it came to describing pain medication for persons that had surgery or something like that. You know, my experience, the stories that I hear is that in hospitals, when African Americans suffer from pain, they're not offered Percocet. They're sometimes not even offered adequate pain medication. And so for you and your son and your daughter to be offered Percocet, and you had to fight after learning what happened to your son, fight to not have your daughter take Percocet, it really shows the contradictions in our healthcare system and the lack of equity in our healthcare system in terms of how some families are treated and other families are treated. So I'll just start there. But I do want to first ask a question. We have, is Dr. William Lawson here, Marcia? Is he on this call? You're muted. You might want to unmute yourself, Marcia. So is Dr. Lawson on the call?
No, I don't think Dr. Lawson is here.
Okay, so we have with us Dr. Edwin Chapman, my good friend and someone who I look to when I want to have any discussion on opioids and the situation with opioids in the District of Columbia and nationally. We also have Dr. Ivy Hilton, who I also have known for. These are community folk, just to let you all know. These are not just luminaries in their field, but these are community folk too. And Dr. Ivy Hilton, I know both her and her husband and have known them for quite some time. And Dawn Valentine, and is Dr. William Booker here as well? Is he here?
I am.
Good. How you doing? How you doing, Dr. Booker?
I'm good, man. Thank you.
Good to see you again. Good to see you again. So I'm just going to go ahead and start with questions, and we will kick it in. And after this round of questions, I will ask each of our panelists a question, and then we will go to the audience. And so I'll start with Dr. Chapman. What are the non-pharmaceutical interventions that you would prescribe for persons suffering from opioid use disorder for acute pain management? And before you answer that question, Dr. Chapman, I have heard, because you've actually presented to the Health Alliance Network as well on opioids. The way that the African American community comes by way of opioid and opioid addiction is different than that of other parts of the country. And could you share with us the difference in how the African American community is experiencing opioids and opioid deaths as a result of overdose versus what is happening in other parts of the country? It's not because generally by prescription. So could you share that and then answer the question? Could we do a stop screen share? Unless that's Dr. Chapman's screen.
I think that is Dr. Chapman's screen.
Okay, then go ahead, Dr. Chapman.
I think. Or Carrie, do you need to stop sharing the screen? I can't tell whose screen that is, to be honest with you, Ambrose.
That's not my screen.
Okay, there we go.
That's Dr. Chapman. Go ahead, Dr. Chapman.
You're muted, Dr. Chapman, if you're talking.
Yeah, you're muted.
Hi, can you hear me now?
Yes.
Carrie's story was just a perfect intro into the problem. And I'm going to try to define the problem initially. If I can move this slide. Do I have control?
Yes, you should.
So understanding the problem is key. And when we look at the opioid epidemic in the African-American community versus the suburban and rural community, we're really talking about two different entries into the problem. With African Americans, it primarily started, opioids started around the Vietnam era, so about 50, 60 years ago. And usually in the teenage years, and ironically, usually with street drugs. And I will explain that difference as we move forward. And of course, it was described as a moral problem, moral decadence. Incarceration was the treatment. As opposed to the current rural and suburban epidemic, it usually starts in the mid-teens, and it usually starts with pills. And many times it's inadvertent, just as Carrie described. So when we really look at it, and this just shows the development of the brain up to about the age of 20, but actually the female brain is not fully developed until the age of 23, the male brain at 26. So we can see that any drug that's introduced into the system, whether it's alcohol, tobacco, or opioids, has a propensity to enter at a time when the brain is not fully developed. So the chance of addiction, as Carrie pointed out, is much greater in the teenage years. And this is just something that we found recently. There are about 35 genes associated with cannabis addiction, so that your genetics has a lot to do with your propensity to become addicted to any substance. About 8 years ago, hydrocodone or codeine was taken out of cough syrup. You can't give it to a child under 12 because they found that about 20% of children are what we call ultra rapid metabolizers, and they convert codeine into a much more potent byproduct and or metabolite and overdose. So we're beginning to see that there's a relationship with your genetics, your ability to metabolize certain drugs. And most of these drugs are metabolized through the liver, through about 5 pathways. And just a slight genetic change in those pathways, it's called the cytochrome P450 system, determines how you're going to tolerate that medication. And there are all types of opioids. So this is just a short list showing the street names, the commercial names, the common names. So there are many forms of opioids that you would not even recognize as being an opioid. Just recently, I discovered the tramadol. People of West African descent are much more likely to become addicted to tramadol, which is very common in Africa, and it's generally manufactured in India and transported there. When we look at the genetics of depression, about 80 genes are associated with depression. So I'm telling you all of this because you have to put all of these entities together in order to really determine what your genetic risk is to become addicted to any substance. So NIH is now doing research. It's called the All of Us study on 1 million people to look at the diverse genetics of our country, trying to determine what medications one should take or should not take. And that's called precision medicine. So when Carrie described her son's situation, we have to now look at pain as not just a physical pain. We think of pain as physical, but it's also emotional. And so this is a New York Times article really talking about what pain really is. And it's really a combination of things. So when we look at addiction, we really have to look at both the physical and the psychic component of that. And when we put those two together and then combine it with our own personal genetics, we come up with a so-called addiction risk index. So I think the fact that Carrie decided not to have her daughter take an opioid because of the potential genetic relationship was just brilliant and really a powerful statement, because we really don't know without having these genetic profiles, and most people have not had a genetic profile. And if you did have a genetic profile, we're not at a point yet where we can really match your genetic profile with all the medications that are out there. So there are about 80 medications now that have been studied. So when we look at the African-American propensity to use drugs, whether it's opioids or cocaine or K2, our history is a bit different. Our history is based more on 400 years of oppression and racism. And when you look at that history, we now know that even in utero, and you can go back 3 generations, that stress has an impact on your ability, on your addiction profile. So some people call it post-traumatic stress syndrome. But this is just to give you an illustration of rat pups, all from the same mother, but you can see that they're slightly different size, coat colors are slightly different, and this has to do with what we call epigenetics, or the environment, what they ate, how they were nurtured, etc. And you can see that there are differences based on that. So when we look at 400 years of epigenetic stress in the African American community, it really leads us to understand that African Americans are more likely to begin using street drugs as opposed to drugs from the doctor. So that's a difference. This is an article from the Yale Journal of Law, Medicine, and Ethics. I just got off a call with Ayanna Jordan, who wrote this article. And just as I've said, Black people are more likely to initiate drugs, heroin, cocaine, from street drugs. And of course, our history is more in tune to incarceration. So I'm going to stop with this one slide. The gentleman in the middle is a patient of mine, and his history is that both his parents died. He grew up here in Washington, D.C. within 6 months of each other at the age of 10. And he became addicted to heroin at the age of 28. The young lady in the pink dress was molested when she was 11. So her story, again, has to do with the pair of ACEs, adverse childhood experiences, adverse community environments. And the young lady on the far right-hand side basically watched her mother, who was an alcoholic when she was 13 years old, and actually went to the hospital with her mother to find out what was going on so that it wouldn't happen to her. And now she's a licensed therapist and runs her own program in Pittsburgh. So what I'm saying is that we have to look at genetics, epigenetics, and the environment that we're in order to really deal with this. So the approach to treatment is going to be somewhat different for both entities. We really need to know what the genetic profile is of a given family. If you find that there's a propensity for addiction to any given substance, and we don't have that data yet. That's something that hopefully we can assimilate going forward. Now, there's some places like the Inova Health System that's doing genetic profiles at birth on children. But until we assimilate all of that data, we can't tell what medications a person should be put on. So in Carrie's story, what happened was what is typically efficacious to the medical system as it's set up. You go to the emergency room, you have an injury. The mode is to get people in and out as quickly as possible, and they don't want them to come back. So they give them whatever medication, and if it's a broken bone or a sprain, or they're likely to give them an opioid without having any of this information. And so you really have to be self-aware and really make a decision on your own whether or not you want to pursue the opioids now. So we now know that opioid prescriptions are on the way down, but unfortunately, because of other factors in the community, opioid deaths have escalated. And they've escalated primarily because not only is heroin less prevalent, we now have these synthetic opioids that are being produced cheaply and distributed on the street. So in Washington, D.C., 95% of the overdoses are related to fentanyl and fentanyl analogs. And these are not fentanyl pills that came out of the doctor's office or that were prescribed. These are manufactured and synthesized as fake pills, many times looking like Percocet, but pressed into a much stronger product that's 50 to 100 times more potent than morphine. So I'm going to stop there.
Wow, thank you, Dr. Chapman. And I want to go now to Dr. Ivy Hilton.
Ambrose, wait a minute, Ambrose. Real
Yes.
quick, because Dr. Chapman, I really want to answer your question. So, Dr. Chapman, what are some non-opioid pain management options?
So obviously, the most common ones are the NSAIDs, drugs like Advil, Motrin. There are also the so-called COX-2 inhibitors. Celebrex would be one, and aspirin, and of course Tylenol. So those are the general medical or pill forms of relief that we have available. And then there are combinations of medications along with physical therapy, and then heat therapy, sometimes ice, etc. So it depends on where the pain is and the circumstances of the pain. Obviously, if this is post-operative pain, then and you're in a hospital, you're more likely to get an opioid narcotic.
Okay, thank you, Dr. Chapman. And now we're going to go to Dr. Ivy Hilton. Dr. Hilton, could you first introduce yourself and explain what you do, and then I have a question for you. You're on mute, so unmute yourself.
I always do that. Well, good afternoon, everyone. I'm Dr. Ivy Hilton. Everybody calls me Mama Ivy. And I am a native Washingtonian, born and raised right here. I am a licensed independent clinical social worker and psychospiritual psychotherapist. I've been doing this work now, believe it or not, 41 years. And so I'm really pleased to be a part of this conversation because pretty much most of my career, I've been talking about alternative medicine and integrative medicine. And now it has finally become pop culture, actually, in the world of healing. And I serve also as a trainer and in restorative justice practices and an advocate for criminal and juvenile justice reform. But I'm more specifically focused on meditation, sound healing, and holistic practices for wellness and mindfulness practices.
Okay, and so my question to you is, first, what is mindfulness and how does it work as a pain reducer?
So I always say, you know, mindfulness is really is a coined word that has come up over the last 25 or 30 years, but it's something that we've always known and something that we've always done. And that is being in a relaxed state of mind and awareness. That's a simple description of what mindfulness is. It's the ability to, it involves self-regulation of how we pay attention to our lives and pay attention to things that are around us and how we use that information to train the brain to manage what our life circumstances are that cause stress, trauma, and just plain old being upset about things. So being mindfulness is really about, it's a construct of paying attention and being aware of what is around you. And why that is important in the area of pain reduction is because using mindfulness techniques, we can train or retrain the brain to create new neural pathways to address how we experience pain and discomfort. And by shifting our thoughts to positive conscious thoughts intentionally.
So Dr. Hilton, I am going to come back to you on the sonic meditation.
Yes.
I want to go now to Dr. Booker. And Dr. Booker, please share with the audience what it is you do, and then I have a question for you.
Sure. Yeah, my name is Dr. William Booker. This is a pleasure to be here. I'm a chiropractor. I've been practicing in Arlington, Virginia for 24 years, I think it is. Our focus or emphasis tends to be with a younger population, an active population. So we see lots of teens, lots of high school kids, college kids who come to us in pain for a variety of reasons. As a chiropractor, we are an integrative practice. So we have physical therapists on staff, a medical doctor, other chiropractors. And so far I find this conversation interesting because I saw Dr. Chapman using triangles in a similar way that we do when we discuss pain with our patients. We tell patients that pain comes from three levels. There's the structural, there's the emotional, and then there's the nutritional or chemical. And as a chiropractor, we tend to focus mostly on the structural side, but by affecting the structure, we know that it also affects the emotional, and also we do a little work in the nutritional as well. And let's listen to Dr. Hilton about alternative approaches. We don't consider ourselves alternative at all. I mean, most people we see come to us as a first line. We do see some people in chronic pain. We do see young people in chronic pain. And we try to educate them on chiropractic as being a part of a solution, not the whole solution. We partner up with the medical community, and if they're seeking counseling, things like that, involved in the schools, we do that with them as well. But we think that once you understand what chiropractic does from a structural side, it should be considered a frontline approach towards chronic pain.
Yes, in fact, Dr. Booker, I know of a chiropractor here in DC, Dr. Keita Vanderpool. I don't know if you know Dr. Vanderpool.
I don't.
But we've had, of course, I'm sure. And so we've had her present as well. But my question to you is, how does chiropractic strategies aid in reducing pain?
So the first thing is to demystify what chiropractic is. I know that there's a lot of different philosophies out there, but we're very science and structural or structure based. So we educate people that joints move, and when joints move, they put pressure on nerves, and put pressure on nerves, your body responds by having pain. If you're under stress, if you had a car accident, if you have poor posture, you've been sitting at a desk forever, like we've seen with this coronavirus, that the stress on your body, not just the joints in your spine, but throughout your body are going to affect the nervous system. That effect on the nervous system is an irritant. And a lot of times people don't understand that that irritant is a structural or mechanical irritant. And it's not something that really does respond to opioids or medication. It's trying to treat a physical problem with a chemical approach is like trying to put duct tape on a flat tire. That we understand that the actual physical body of the individual is part of what's going into their pain. So again, our focus is primarily structure, and we educate people to the relationship of nerve irritation, pain, and the symptoms that they present with.
Okay, thank you, Dr. Booker. And I will get back to you with another question as well. And now we're going to go to Ms. Dawn Valentine. Ms. Valentine, could you introduce yourself, tell us what you do, and I have a question for you as well.
Okay, hi, my name is Dawn. I am a yoga therapist. I came to this practice after doing about 20 years in public health and public health research, where my goal was to actually sort of impact people's health and make it better. Didn't really work out that way, regardless of which way that I tried. And along the way, I got interested in consciousness. And I'm a 20+ year practitioner of yoga. And we typically talk about yoga in a very Western way, which is to talk about just the movement. We fail to see the entire spectrum. And so what we do in yoga therapy is we start to talk about that whole long history, and we bring people sort of into a state of what we call wholeness or balance. And so today, that's what I work on most. I work in both, in public health world, how do we think more about consciously, cultural awareness and that kind of thing, and how do we apply that to research and evaluation, and then also yoga therapy to sort of bring things up. And like Dr. Booker and like Dr. Hilton said, a lot of the work that we do is we partner with other people, so like you don't just do yoga, right? You might go see someone else for meditation, you might go see someone else like a chiropractor or a doctor. We just sort of sit in the middle and work on the whole body or the whole person.
That is fantastic. And I just want to say, I vouch for yoga. I took yoga for 2.5 years. I am so sorry that I haven't gotten back to it over the last 7. I miss it so much.
We're here for you whenever you're ready.
And I'm coming too. And especially now that and I do want to say, you said that you do yoga therapy.
Yes.
So I'm wondering whether or not that is something that is covered in insurance. When you say therapy, I'm thinking insurance.
Nope.
And something that should be covered in insurance. Is that right?
I don't necessarily know that. We have far different explanations for outcomes, and it's sort of a big thing in our community about should this be covered by insurance or not. And that's kind of a bigger, more difficult question. If you go see a doctor, you have this expectation that something is going to end. With yoga, it's more about coming back into balance, and because we take a very different view of what's well and what's not well, I'm not sure that it's going to collapse well into sort of the system. There's no one system or one pathway. Everyone is unique. When you show up on my mat, you're unique. So we're going to do different things.
So how does yoga work on chronic pain?
So what we basically do is neuroplasticity, right? So we typically start to work to change the association that you're having with your pain center. So my work typically involves trauma. So that trauma usually branches off in different ways. Some folks have addiction, some folks have had other historic traumas, and the pain is sort of the thing that resides in the body. And so for us, when we're working, we only work with what is in front of you. And so whatever that complaint is, if it's like, my elbow's hurting, we'll do some things to work on the elbow, right? But then at the same time, we're also going to work on probably your shoulder, because if you've had persistent pain in your elbow, you're going to like move your whole body to adjust for the expectation of pain there. And so we're going to work to sort of realign the body. And then usually in doing that, we start to, other things become revealed, I would say. And then we just work with those things as they come.
So in my journey coming back to yoga, I have what's called a yoga cube. As you can see, the namaste position, and you can see other positions.
Yes.
And so what the goal is to, for example, just roll the cube and then do that position.
All right.
So that's on my schedule. I'm going to be starting that this winter. I'm just letting y'all know. I'm getting my yoga right back in. All right.
Let's go.
And Ambrose, to tease you a little bit more, there's a lot of good yoga online. I can send you some YouTube links, brother.
All right. Thank you.
We can bring a whole class into your house.
Thank you, Roz. And I'm going to come back to Dr. Chapman now, and kind of ask two quick questions. One, what are some of the challenges in prescribing the types of interventions for a person suffering from opioid use disorder? And then, do you have any recommendations for increasing access to alternative treatments?
So that's a tough question. In this arena, and I'm going to say for at least the past 7 or 8 years, it's become increasingly difficult to get away from the 3 standard medications for opioid use disorder. And those 3 medications are methadone, which is the oldest, more recently buprenorphine, and then finally Vivitrol or naltrexone. And each one acts a little differently. And the reason why I say that is because this shift to synthetics has really put us in a vice. We're talking about street drugs that are 50 to 100 times more potent than morphine. So when we look at a Percocet pill, we're talking about something that's and it varies because we don't know who makes it, and we don't. These are street chemists, and that's what makes the overdose propensity so high. So in about 2015, in the District of Columbia, and really according to the chief medical examiner who was on yesterday, they really started seeing fentanyl laced in heroin in about 2013 or 2014. But in 2015, we realized that about 20% of the heroin on the street was fentanyl. Today, 95% of the so-called heroin on the street is fentanyl. So the deaths that we're seeing are almost always associated with these synthetics. And if we go back again to the story that we heard to start this, if a patient, so the standard of care from my perspective and from NIH perspective is medication-assisted treatment. You need to be, if you have an opioid use disorder, you need to be treated medically on one of 3 medications. Of course, methadone is what we call a full agonist. It does everything that morphine does, including depressed respirations. Buprenorphine is a weak opioid, but it has a very high affinity for the opioid receptors in the brain and the intestinal tract. So it's called a partial agonist, and it's less likely to cause respiratory depression and overdose. Vivitrol is an injectable or naltrexone antagonist, which also binds to the opioid receptor sites and reduces the chance of dying. So we're really in a bind. I've treated over 6,000 patients over the past 20 years with opioid use disorder. About 5,000 of those were in a methadone clinic, and about 1,100 in my office over the past 15 years. 15 or 16 years. And I can count on my fingers and toes the number of patients who actually were able to get off medication-assisted treatment, and as far as I know, survive. So it's not, it's not something that I can do and not worry about malpractice at this point in time. It's very, very difficult. So the patient has to say they're going to do it, and I've had a couple of patients to do it. They just stop and come back and done well. But these were generally patients who were on opioid pills and not the street drugs.
Thank you. And Dr. Booker, do you, and I'm gonna come back to you, Sister Ivy, Mama Ivy. Do you accept payments directly, or do patients pay up front and seek reimbursements for your services?
Yeah, we accept most major medical insurance. And obviously we do have a cash plan for patients as well. So we have all options.
Okay, thank you. And how are individuals referred to your services?
We've been doing this a long time, so we have a lot of word of mouth. We work closely with a lot of the top sports teams in the area. We're affiliated with Nike's basketball program, youth soccer, a lot of track programs in the area, a lot of high schools. So mostly word of mouth, a little bit of Facebook, but I'm a little too old for all that. I just kind of old school, get the word of mouth referrals.
Okay, and Don Valentine, I wanted to ask you, how would a yoga therapist support someone with chronic pain, and is this costly?
So so we don't use chronic pain. We call it persistent. The chronic is kind of changes the state of mind. So how it works is you would come see me. It's not like having a regular yoga class, right? So you don't come every week. What happens is it's kind of like a bit of an experimentation. We'll spend the first couple sessions sort of working together and seeing like what's working for you, what's not, is it fitting into your lifestyle, things that you consistently do. And then once you have that, you're going to do that for a while and you don't see me. So that could be as much as 6 weeks before you see me again. And I'll check in with you each week to make sure that you're progressing. In terms of how does that work out in terms of costs, that's something that we negotiate at the beginning. So for some people, like we'll agree to 4 sessions and then we'll see sort of how that goes. I work a lot with different programs. And so sometimes for those types of programs, you will see me on a weekly basis because it's more of a group effort. But and in between, people do other things. So they might go see like Dr. Chapman or might go see Dr. Booker or what have you. But yeah, we work with budgets and we sort of tailor things to fit your need and your lifestyle. And, at the end of 4 weeks, we would see if you need to continue, if something else has come up, do you have enough? And I think the difference here that I would point out is in yoga therapy, I'm not the driver, I'm the facilitator. You are the driver. I'm going to give you a practice, right? And you're going to tell me, yes, no, yes, no. I'm like your textbook. I'm giving you different things until we get the combination that works. But it is actually the person who's suffering from persistent pain that's in the driver's seat, not me.
Thank you. And so Mama Ivy, coming back to you now, could you take us through and demonstrate sonic meditation?
Okay, well, I wanted to add to, while I'm setting it up, that the whole idea of this particular exercise is the use of how sound and brainwave entrainment actually supports all of these therapies that we've been talking about. Much of stress, trauma, and pain that we experience comes from how we think, what we believe. And the possibility of creating wholeness has to be an internal truth. So using this type of meditation, sonic meditation, which is using crystalline frequencies. And these frequencies speak to the brain in various brainwave levels. You have alpha and theta brainwaves that we are really primarily focused on reaching. And we believe that research has shown and proven to us now. I've been doing it long before they started doing the research. I thought I always keep telling myself, wonder why I didn't do that. But you know, when we're working in the community, feet on the ground, that's all we're really focused on. And I realize that's something that in our community, we need to spend more time doing the research to show those therapies that work best for us in our own communities. So when you integrate the crystalline frequencies with intentional thought forms, it creates instant manifest. And this is how we create new neural pathways for thinking. And I make it simple that I ask the question, what sees, the eye or the brain? And it's actually the brain is what sees. So if we close our eyes and we create those images in our mind, it speaks to the autonomic nervous system. So I'm going to be taking you through how much time do we have, Ambrose? Oh boy, my little puppy.
We have, I want to dedicate the last 20 minutes of this to questions and answers from the audience. So
okay.
You have about 15. You have about.
Oh, okay. Well, what if you guys don't mind? I need to close my door. My little puppy is barking at a bunch of cats that are in my yard right now. So please hold on 1 second. Hush.
No problem. Hey, Ambrose, there was a question for Dr. Booker while Dr. Ivy is.
I did see that, Roz, and I'll get to that as soon as I finish.
Yeah,
okay. Did you want to take those questions first?
No, I didn't know you were going to be gone so quick. No, go ahead.
Oh, I just needed to close the door. Baba Salim is not here right now. So, so the first exercise that I want to take you through is an integration of what we call yoga nidra, which is a mind yoga that you don't use your body, you use your mind. And this sonic meditation, I call it quantum focus, because what we're doing is training our brain to create new thought forms so that we don't get so caught up in the pain and feeling the pain, but then we are focused our attention on what it is that we need and intend to create and manifest. So the first frequencies that you're going to hear it comes from a crystal harp that is made of pure clear quartz crystal. And it looks just like a lap harp, a lyre. And I'm going to take you through an introductory yoga nidra practice. And this is how we begin to teach the brain how to refocus its attention onto bringing health and wellness. So I'm going to ask that everyone that can hear my voice, if you can, to just, and if you don't want anyone to see you with your eyes closed or meditating, you can turn your video off for this exercise, but you don't necessarily need to see me. I just need you to hear my voice. Now, Yoga Nidra is known as a sleep meditation, but it really is a way of practicing to control the thoughts, the mind, and the body. So I invite you to simply, gently close your eyes. And take a deep breath in through the nose, filling your lungs with air. And exhale gently through the mouth. And as you exhale, allow your shoulders to droop down, 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 deeper into relaxation, deeper into surrender. Take another deep breath in, filling your lungs with air, and exhale. And one last breath, take a deep breath in through the nose, filling your lungs with air. And as you exhale, allow your shoulders to droop down even deeper into relaxation. Letting go, letting go, letting go. Going deeper and deeper into relaxation, deeper and deeper into surrender. And now, I invite you to bring your awareness to the center of your left palm. With your mind's eye, look inside of your palm and look around. Notice if there's any tension, discomfort, or pain, and let it go. Letting go, letting go, letting go. Going deeper and deeper into relaxation, deeper and deeper into surrender. And now, bring your awareness to the center of the palm of your right hand. And look inside of the palm of your right hand with your mind's eye and look around. Notice if you see any discomfort or tension or pain, and let it go. Letting go, letting go, letting go. Going deeper and deeper into relaxation and even deeper into surrender. And now, bring your awareness to the muscles in your shoulders, in the back of your shoulder and the side. And with your mind's eye, look inside of your left and right shoulder and look around. And see if you notice any tension, discomfort, or pain. And let it go. Letting go, letting go, letting go. Going deeper and deeper into relaxation, deeper and deeper into surrender. And now, bring your awareness to the center of your heart and look around. If you feel any tension, discomfort, or pain, let it go. Letting go, letting go, letting go. Going deeper and deeper into relaxation, deeper and deeper into surrender. And now, bring your awareness to the back of your eye socket on the left and on the right. And look inside of your eye and notice if there's any tension, discomfort, or pain. And just let it go. Relaxing the muscles in the back of your eye socket. Letting go, letting go, letting go. Going deeper and deeper into relaxation, deeper and deeper into surrender. your attention to your fingers and your toes, and just slightly move them very gently, very slowly. And notice each finger, and notice each toe as you stretch them out and contract. Stretch them out and contract. Letting go, letting go, letting go. Deeper and deeper into relaxation, deeper and deeper into surrender. And now begin to bring your awareness back into your space, noticing your body, aware of the room and the chair that you're sitting in. And take a deep breath in through the nose, filling your lungs with air. And as you exhale, begin to slowly open the eyes, blinking them 2 or 3 times before you open them completely. And welcome back. So I'd like to just take a few moments as you're bringing yourself back, for those that are back, to share with us your experience.
Ivy,
Yeah.
we can't hear you.
Oh no, you didn't hear me?
Yeah, we heard you.
Okay, it was really low. Is it on my side? Okay, maybe it's on my side, but I was hearing you better before.
I think it was intentional, Roz.
I can't hear it either.
I couldn't hear either. I was bringing it down.
Yeah.
Okay.
But I'm back now.
But I couldn't hear you at all, and you were still talking. That's why I thought. That's why I didn't say anything before now.
Oh, okay. But you heard the meditation though, right?
Yeah.
Yes. Okay. I mean, I know your technique. Okay, never mind. I'm gonna be quiet.
All right.
But you were talking and I couldn't hear you at all. I like absolutely no sound. That's why.
Oh wow.
At the end. Just at the end.
Okay. All right. Are you back yet? Anybody want to share?
Yeah, I'm back with a with a clarion call.
All right, talk to me.
No, I was trying to work my way back, and then Roz
came out. Wow. That's a moment where we're very
shock trauma,
very silent.
I'm sorry. My bad.
We're gonna go on a one-on-one, Rosalind.
My bad. I didn't want people to miss your chimes because I couldn't hear any of that at all. Anyway, okay, I'm sorry. My apologies.
All right. So just take a deep breath and come back.
Hey, Roz, I'm traumatized.
Look, guys. Okay.
So we have one more. If you give me 2 more minutes, I might be able to
join her every Thursday.
Bring you back. Oh yeah, tonight we're doing it on Facebook.
That's right. You can have a full session with Dr. Ivy on Thursdays, uninterrupted by yours truly. How about
Right.
But moving forward, if we could hear from somebody.
Well, do you need to continue to share your screen, Dr. Hilton?
Oh no, I'm gonna let that, unless you all want to do like one more to revive.
Dr. Lawson had just signed on. I hope he is still there. And initially.
Okay. So I stopped sharing now.
You're here.
Okay, good. So I know that
Dr. Lawson. Let me go. All
I
right.
don't,
So
yeah.
we'll go right back into the discussion. It's good to see you again, Dr. Lawson, as always. So I just wanted to ask you really quickly, mental health plays a vital role in recovery of a person suffering from chronic pain and opioid use disorder. Can a person's mental health be treated with alternative strategies? And you're muted, so you might want to unmute your, go ahead and unmute yourself, Dr. Lawson.
Yeah, you're absolutely right. Bottom line is that chronic pain and depression and anxiety are intimately related to each other. Treat the depression, the pain is less worrisome. Chronic pain leads to depression. Now the question is, I hear people using alternatives. The problem is that most of the alternatives that you get on in the news and sent in your email and ordered, usually they include active ingredients in them. There's one study showed that when you test some of these alternative medicines, they weren't really alternative medicines. Are there any that really work? Probably, but the problem is that let the buyer beware. By definition, many of these alternative approaches are not FDA approved, have not been tested, have not been gone through clinical trials. So let the buyer beware. St. John's wort has been shown in NIMH to treat some depression. Not sure if it does very well with chronic pain, for instance. And that's CBD oil, very mixed results. So then that's the that's the one that's most popular right now. So so be very careful. Some of these alternatives are frankly dangerous by definition. They often, and they put the disclaimer, not to be used for any kind of treatment of any kind of disorder, or they'll say that it's not undergoing any kind of clinical trials or anything else.
So we also had presentations from a meditation expert, Dr. Ivy Hilton, and then Dawn Valentine, who teaches yoga therapy. And I wanted to ask whether or not these strategies can have a positive impact on mental health, and should they be done in combination with other mental health services?
It can be done. Yoga, there's been clinical trials, NIH funded through their alternative section, showing that that yoga works. I use hypnosis; it works. So there's a number of these procedures that's actually been tested and have been found to be found to work, and also that can be used in combination with some of the standard treatment. On the other hand, I tend to lean in the direction of a lot of folks who do not use a lot of opiates or benzodiazepines as way of dealing with substance abuse and pain treatment. They can work, but sometimes the abuse potential greatly outweigh the benefits that they bring to the situation. So it has to be done under appropriate care.
Okay, and before we go to questions from the audience, Dr. Lawson, just kind of share with people your background and the work that you've done.
Basically, recently ran the chemical dependency unit over at in Montgomery County. Currently, I'm doing primarily mental health substance abuse services through telemedicine on 4 states. Past chair of psychiatry, Howard University, was the assistant to the dean at setting up the Dell Medical School, was the chief at the VA, and also has had appointments at several universities right now. I'm adjunct professor at University of Maryland and emeritus professor at Howard and Dell Medical Schools. And did a medical degree from University of Chicago, residency Stanford, PhD, University of New Hampshire, and has set up several substance abuse programs.
Okay, and so now we will go to questions and answers from the audience. You can certainly put questions in the chat, but I wanted to get back to a question that was posed to Dr. Booker, and that was from Talia Gilia. And she asked a question: a few years back when I was receiving chiropractic care, I found out that in DC, this was not covered by insurance. I don't remember if this was Medicaid or included other insurances. Do you know if this has changed now?
That's a broad question. Medicaid is tricky, not just in DC, but pretty much across the country. But as far as major medical goes, your Aetna's, Blue Cross, United Healthcare, things of that nature, they are covered in DC, Virginia, and Maryland.
So those are the PPOs as opposed to the managed care organizations.
Mostly, although the managed care, if you're in network, so we're in network with United Healthcare, for example, and Blue Cross. So that would cover PPO and the managed healthcares.
Yes, absolutely, absolutely. All right, now are there other questions?
Sorry, just real quick. This is Talia. Just real quick to follow up on that. But you're in Virginia. I just remember I was a new DC resident and I was trying to get some chiropractic care and I was looking into getting insurance. And I remember my chiropractor told me, he's like, well, this isn't going to be covered. Actually, in DC was like very specific about DC that that coverage had been blocked or was being blocked. It was like it wasn't anyway. It just wasn't. And so anyway, so that's why I asked the question. But I'm really glad to hear that at least in Maryland and Virginia, it's covered. And maybe for DC residents, maybe that's also covered now. Is that what you're saying?
Again, it depends on the plan that you have. One of the things that we're able to do is because we have physical therapists in office, we can offer a wider range of insurance options. So what your chiropractor in DC may have been saying is DC used to be very restrictive as to which codes you could and could not bill. And at the end of the day, some of the codes just made it not worth it for the chiropractor to accept a visit. But A, that's changed a little bit. But B, as I said, if you also had other providers in office like we do, it allows you a wider range.
I got you. Thanks a lot.
So are there any other questions for our panelists? You can raise your physical hand or you can raise your virtual hand. I'm able to scroll through all of the participants. And so if you have a question, please just bring it. Let's see, is there anyone? And you can unmute your mic as well. So I'm not seeing any questions as of yet.
Well, Ambrose, I know that Dr. Booker, good childcare, he has to pick up his son. So I know he's going to have to leave us. So if anyone has any priority questions for Dr. Booker, but the insurance piece is important, I think, for all the alternatives, so-called alternatives. And it sounds like it depends on what kind of insurance you have, as well as what type of services your provider is providing, more so than your physical location. Dr. Booker, would you agree?
Yeah, more or less, that's correct. Yes.
Okay. And thank you for your time today.
Thank you. This has been a lot of fun. Thank you.
So as a general comment, many of the alternatives to pain and alternatives to pain medication, as we've talked about here tonight, are not necessarily reimbursable under DC Medicaid, and that can be a problem. I mean, there are alternatives that do work for the management of pain. I know that as someone who is a master trainer in chronic disease and diabetes, one of the things that we cover in the classes that I teach is about the management of pain. It's part of the toolbox that we use, and actually how to use the mind and the strength of the mind is one of those tools in the toolbox. We go through an exercise with our participants where they close their eyes and they imagine a lemon in their hand, and then they imagine biting into that lemon. And you can see people's reaction thinking that they're biting into a lemon, which shows you the power of the mind, that you can actually generate the sour taste of the lemon in your mouth when you actually have nothing in your hand. And so that should tell you the power of the mind in addressing pain and addressing chronic disease. But many of these things are not covered by insurance. And so I wanted to go back to Dr. Hilton and ask, what are some of the practices that someone can use? You talked about the sonic meditation, but are there others? Unmute yourself.
Yes, there is sitting with your breath, like we did just a few minutes ago. It's amazing how the breath is a free elixir. And you can practice your awareness of your breath and just sitting there and watching your breath go in through the back of your throat. And it's something about being able to pay attention to the process of the body, being mindful of it. You can sit with sound like we did before. You can sit with your thoughts and your feelings rather than going deep into the trauma of pain. You begin to explore the feeling of that. And sometimes when you can become more aware of when pain is coming, you can know what to do to try to avert it. Rather than pain sort of showing up for you, chronic pain. And I practice on myself from many severe car accidents. That's how I really got into this practice for my own wellness and my own health care. You can sit in the silence and just pay attention to what is around you and just slowly breathe. This whole idea of being non-judgmental when you see things, when you observe things, noticing the stream of judgment in your mind, the good, the bad, natural, whatever it is that's going on, so that you can begin to get in touch with your thoughts and create new intentions that help you become more mindful. There's this practice that I really like called mindful eating, where you don't just take your food and take it all down. You pay attention to how you're preparing the food. You pay attention to where the food comes from. You pay attention to, I wonder who it was that picked this fruit, or I wonder who it was that prepared this meal. And as you're eating it, you start to pay attention to the taste, the aroma. You start appreciating the value of life that is around us, because a lot of times we get caught up in the moment and get very distracted by busyness. And that's the last thing that I'll share about being busy. Sometimes you just have to let it go. Whatever it is that we're holding on to, letting go is a way of letting things just be and accepting them for what they are. Letting it go rather than holding on to it is a very powerful mindful practice.
So there's another person that some of you may be familiar with, Io Handy Kendi. She is what we call a breathologist, which teaches about the use of the breath. And in fact, even in yoga, and I'm sure that Ms. Valentine can attest to this too, how important breathing is in yoga. And there are different, even in yoga, there are different types of breathing. I remember when I was taking yoga, one of the types of breathing that we did was dragon breath. And so, it's a different kind of breathing. It's you would think at first that you're hyperventilating, but you're not. It actually doesn't, you actually don't hyperventilate if you do it correctly. So I know
you're creating endorphins when
you're creating endorphins. And so if you could speak to the breathing piece, Ms. Valentine, that would really seal the deal. Go ahead.
Okay, just really quickly, I was trying to put this in the chat box. I'm not sure if it came up, but someone mentioned acupuncture, and I just wanted you all to know that there's a place in Adams Morgan called Little Bird Acupuncture that offers these services on a sliding scale. I think their lowest price is 25 and their highest is 50. And so I just wanted to make sure that you all were aware of that particular service in the district. They do great work. In regard to breathing, yes, right? Like it's the one thing we do every day. And if I say to you, what's your favorite breath? You're going to be stumped, right? Like, what? I don't know. The thing about it is we use different breathing techniques for different things. So, for example, if you think about your life, we start life on an inhale, right? We gather courage on an inhale. We always start on an inhale. And when we let go of things and when we pass, we always end on an exhale, right? So, right, you know, were you ready to chime up? You'd be like, ready, right? You know, and so we play with these two breaths depending upon where you are. I believe it was Dr. Lawson that talked a little bit earlier about people with pain. Sometimes they actually have a lot of anxiety. And so that actually increases the pain. And so we do different breath work for that. Sometimes we encounter folks who've got more depression and we do different practices for that. The last thing I will say is we also do a lot with sustaining the breath. And it's kind of an interesting factor that when you inhale and you try to hold the breath in, there's something about holding in that our bodies don't like, right? Because what happens when you start to hold in, you want to escape. And you know what? You would think if you held your breath in, you'd want to exhale. That's not what happens. You try and take in more, you get greedy. So you're like I need more, right? And so a lot of what we do is in breathing is we learn to time breath with movement. And so can I show you a little exercise here real quick? Just to kind of, okay. So if you can kind of take a straight back, if you will, right? And just so you can get full feeling in your chest, just breathe in some air through the lips, right? And you're going to feel the chest start to expand. And then once it feels full, just exhale it out through your nose, nice and slow, right? And just do 3 of these. So inhale through the mouth. Take a little pause, like when the chest feels nice and full, and then exhale out through the nose. And do 1 more of those, right? Inhale again through the lips. Take a little pause, exhale out through the nose. 1 more. Inhale 1 more time through the mouth. Take a little pause, exhale out through the nose. Okay, your next inhale, just breathe in through your nose, just quite naturally. And as you're inhaling, see if you can just start to inhale and drop that right ear to that right shoulder. And just take a breath here, in and out. Another full inhale. And then exhale, let your head rise back up. Right. On your next inhale, let your left ear go to your left shoulder. Take a full inhale and exhale here. On your next inhale, let the head rise. And let it out through your mouth. Okay, that was not even 20 seconds.
Right.
And you start to see how already you start to feel a little bit different. We remember we've got big lungs. We remember like where we are. And the last thing I'll say, the most important part I think about breathing is our minds are homeless. They're forever stuck in the past or they're always moving to the future. And it's hard to stay right here. And when we use the breath, it sort of is an opportunity for grounding. And so we can sit in this present moment. And like Dr. Hilton was just saying, so now we know when we're in this moment, we feel that pain. And before we tense up and give into it, we can make another choice, right? Or we can prepare ourselves and let go, right? And so like we see that in Lamaze. What is that? That's breathing and learning to let go so you can sort of have this birth experience. And so that's just a quick 30-second roundup, I think.
That was wonderful. I know that when I first began taking yoga, I used to hold my breath, and my instructor really showed me and taught me that you have to actually breathe through your poses.
Yes.
And so once I learned how to breathe through my poses, you actually can sink into your pose with your breath.
Yes.
And it's easier to do the pose. Now, I didn't become no yoga expert. I was, probably moving from beginner to intermediate. I'm not going to kid you.
It's you know what? It's not.
Right.
I know there's a lot of pictures about yoga, and I would just encourage you to remember that's not the goal. The goal isn't to master the pose. The goal is to master the emotion in the pose.
That's right. That's right.
Yeah.
That's right. So thank you. I'm going to go back to any last words from Dr. Chapman. I know that you've shared a lot with us, and is there anything else that you want to leave us that we should be remembering?
Yes, and I think you really hit on a key component of this. We could use a lot of these alternative therapies because the patients who suffer from opioid use disorder also have other problems like chronic pain. And they typically will supplement that treatment with other opioids or with benzos, you know, so having the opportunity to use alternative therapies would be fabulous if we could get the insurance companies to pay for it. But we don't have that option. You know, it's like we're in a straitjacket. We know that our patients are suffering from depression and anxiety, and if yoga and breathing exercises will reduce that, then obviously some of the other symptoms, as Dr. Lawson talked about, would improve. But we just don't have that in this very straight jacket situation that we're in with the insurance companies, who are pretty much dictating what works and what doesn't work. And if they won't pay for it, our patients can't afford it.
Let me add another point to that is that one way we can get some results is to go out and make sure that we can get some of these products into clinical trials. We're doing one now where we've got Small Business Administration supported using odeons. So folks in breathe that stimulates the hippocampus so that they remember after they go through substance abuse treatment what happened, and we're getting good results. But again, we have to get the clinical trials done so that we can provide the evidence to the insurance companies so that they will pay for it. If you will pay out of your pocket, you can do any of these techniques. But the problem is somebody, if you don't have the money, somebody's going to have to pay for it. And even when it's approved, as Dr. Chapman alluded to, the problem is that sometimes you have to go through an administrative nightmare in order to get the paperwork done to show that as you can justify to these companies that the treatment should be paid for.
Absolutely. Thank you, Dr. Lawson. Dawn Valentine, do you have any last thoughts you want to share? You're muted.
Yeah, I'm sorry about that. You know, I would say this just about yoga is, you know, the one thing I would encourage anyone who feels like that they want to try yoga for pain is to really seek out a teacher. A lot of us give away stuff for free. We call it our karma yoga. We don't necessarily always advertise it, but it always helps to ask. And the last thing I would say is not to confuse what happens in a class with what happens in therapy. They're kind of two different things. In a class, we're guiding multiple people through a practice with our intended goal, right? When it's a yoga therapy or a personal one-on-one, it is about you and it's about your needs. And so there is just some differences there.
Thank you. And that was one of the questions. I'm sorry I didn't ask it, but I'm glad that you covered it. Thank you very much. And last but not least, Mama Ivy, if you can share with us your last thoughts.
Well, my last thought is that if we can begin to embrace these natural alternatives, that we can shift and change the quality of our lives. That if we could begin to practice being mindful, practice meditation, experience sonic healing, and see how it affects your body, and then make your own determination of what type of a regime you can use to improve the quality of your life. And I encourage everybody to explore it. What mindfulness, alternative medicine, and integrative medicine is. Find out what it is and demand it from your healthcare professional.
Or something. Okay, bye.
Thank you.
Okay, thank you, Dr. Hilton. And so now, Marcia, if you want, go ahead and take it away.
I just want to thank my panelists for this incredible information that you have provided us. And I also want to thank all of the participants. If our panelists could very quickly put their information in the chat box, because I have some folks that would like to reach out to you again, that would be great, okay? And everybody, please be safe out there. And thank you. That's it for me.